Well, welcome everyone to our next in the series of workshops on hearing. An opportunity for all of us to hear more about hearing resources in the community and to learn about hearing. I will introduce our speaker today, who is from the community. But before I do that, I want to mention something that you heard about from Lori in one of her three things memos. Len Gross and I have been using a sound meter to measure the background noise in some of the community spaces. And all one needs is an iPhone and an app, and it turns your iPhone into a sound meter that tells you what the background noise is wherever you happen to be. And so if you're in the dining room or you're in the cafe, you can actually see what the sound is around you. And it makes you very aware of how much you have to raise your voice in order to be heard when you're in a situation with a lot of, or a high level of background sound. And in order to get the app, which is a free app, which was developed by the CDC, what you have to do is go to the Apple App Store, and I've put together an instruction sheet for you, and you can download the app, and it will explain to you how to use it, and Len has some copies that he'll hand out if you're interested in doing it. And we have an ulterior motive in asking you to do it, and that's that if you use the app wherever you are meeting others, in the dining room, in the cafe, if you turn your phone on and record the background noise for 15 minutes, that will give us a good idea of what the noise level is in that particular area. And the app is set up so it's very easy to email it to us. And that's going to give us an idea of background sound in the various places that we get together. Len and I will be doing it more systematically in the dining room. So you'll see us with our iPhones, and we may be asking you to let us put our iPhones on your table for 15 minutes. So, thank you. The app is not developed for Android, so it has to be an iPhone. Yeah, good. And now let me get on. Excuse me. So, let me get on with the business of the day. Cliff Carey, who is from Timeless Hearing, has come to talk to us about hearing evaluations, advice about hearing aids, the several different brands of hearing aids, follow-up function of hearing aids, maintenance of hearing aids, all of those things that those of us who are concerned about hearing and want to know about the resources in the community need to know. So, Cliff, without further ado, would you like to go ahead?
Of course. Thank you so much. Thank you all for being here. Can everyone hear me all right? Fantastic. So as we were going through the planning of what content we would discuss today, we found that it was a wide-ranging conversation, and Marguerite and Len and a few others were in the room with me, and what I kind of felt like we might have wanted to discuss when the conversation started ended up being insufficient. compared to what we ended up discussing and thought might be relevant to the overarching conversation that you're having here as a group when it comes to the types of resources that you'd like to have as residents. So I ended up having a general overview put together and broken down into 3 main categories. So one is a discussion about the type of providers that are available for meeting different conditions of the ear, dysfunctions of the ear. Can discuss with you the credentialing that is required for each, the core competencies, sort of the scope of practice for each, where they overlap and where they don't. The second portion is going to be more about the types of tests you may want to be inquiring after when you're meeting with a provider, because not all providers are going to perform all of these verification and validation tests that can help to really pinpoint, triangulate, and describe the complexity and exact nature of hearing loss. So we'll go through a few of those. And then I wanted to talk specifically about hearing aids as well. There's a lot of information out there, a profundity of information, I would say, so much so, in fact, that it is confusing. So I really wanted to give you some take on technology, things that you should be trying to educate yourself about, questions that you ought to bring to a provider that you might be working with, or if you're working with a manufacturer directly in some capacity, you can more intelligently ask questions of them about device performance. And then I thought what might be fun, if we have some time at the end, is I brought about 5 different case studies of patients with self-reported hearing challenges. I'll give you their audiograms as well, so you can actually see what their hearing loss looked like on paper. And then I'll show you what we ended up doing in order to treat them. It's pretty high level. I've removed all of the sensitive data that might get us into HIPAA trouble, but I think it'll at least give you an idea of just how varied and variable and subjective hearing loss and treating hearing loss can look. And that way maybe you can take some of those same things back to your residences and start to contemplate where you're going to get started with your own journeys. Does that sound like a good plan? All right, and then hopefully we'll also have some time for questions. And no questions are off limit. I am very comfortable with even the most challenging of questions, or the ones that you may think are the most challenging, and I can help to at least get us pointed in the right direction if I don't have the exact answer. So again, the agenda here, and I wanted to start first by describing the anatomy and the biology that goes into helping us to hear and, of course, process speech. Does this look familiar to anybody out there? All right, so this is our auditory system, and it is made up of 2 different parts. First is your peripheral auditory system, which is mostly comprised of your ear, your outer ear, middle ear, inner ear, and the auditory vestibular nerve. There are 12 cranial nerves. For any of my MDs out there, they'll remember that there are 12 large nerves inside of the head, and nerve number 8 is your audiovestibular nerve. And the information that's collected in your peripheral auditory system travels along that nerve. Those 2 nerves braid together just below the brainstem. And along that pathway, there are all these different gates that the sound information travels along that our bodies can determine things like localization of sound. There's actually a really neat gyre just below the brainstem where sound gets processed, and it actually tells us when speech starts and when speech ends. And when we have dysfunction in that tiny little gyre, which is just a collection of synapses, is really all it is. When there's dysfunction there, sometimes we don't catch the first couple words that someone says, and then suddenly we start hearing, we see their lips moving, and then it kicks in, right? And so that is a dysfunction in our peripheral auditory system that can lead to challenges in the way that we communicate with people. Oh, and by the way, you may test out within normal limits on an audiogram and still have that type of dysfunction. So it's really, really interesting the type of things that could go wrong as speech information travels along this pathway. Once it hits your brainstem, those you've got 30,000 neural connections on each side They braid together into this 60,000 neural connection stream that heads into the central auditory system, where speech then gets processed. And there's a couple different areas in there. Wernicke's is where speech is really decoded. And then, of course, we're getting both speech and balance information at the same time through that system. And then those are separated again. So if we have trouble separating those things effectively, then we can have an impact in our balance or our speech. And some of these things are called central auditory processing disorders. And again, that can look very much like a hearing loss. And then you go in to get a hearing test, and you have normal hearing when it comes to pure tone audiometry, but you're having difficulty processing and uncoding the speech information. So there's a lot of areas where things can go wrong, but in most human beings, everything goes well. But I will tell you that 200 years ago, and really it's actually sooner than that, so about 150 years ago, the average life expectancy of an American was, do you guys know? It was under 40. It was about 38 years old. It was 150 years ago. And through the vast majority of human development, which is a couple 100,000 years now, we didn't live past our mid-30s. The elders maybe lived into their 40s or 50s, but most people passed away long before that. So a lot of our systems, the functionality of our body, especially the minute intricacies of some of our organs, they start to give up sometime within our third or fourth decade. And what you can actually see is in all mammals, they exhibit age-related sensorineural hearing loss somewhere in this, what would be for us our third or fourth decade, but for something like a rat that doesn't live all that long, it's going to be in a very much similar time frame of about midlife for them, just before midlife. And it's something that just happens. And that's why research that's done in the audiology field is done on rats, because we can model what the progression of sensorineural hearing loss looks like across all mammals, which is fantastic. And in fact, I know a PhD audiologist. He's actually a PhD neurologist, and he has a clinical doctorate in audiology. He's a dear friend of mine. He worked at MIT for a long time in the rat laboratory, studying if they could regrow hair cells. If you ever have any questions about what they're doing with gene therapy or anything like that, I can answer some of those questions for you too. I guess quick note on that, it's not promising. So I would not expect gene therapies or stem cells to help us to hear better anytime soon. But it's fascinating that type of research is ongoing. So again, this is your sensor, your auditory processing system, and those neural connections, well, they're kind of like braided rope. So unfortunately, what happens over time is they start to get frayed, and they start to, unfortunately, stop communicating effectively. And it's actually clinically proven that you can have 80% of your neural connections on either side be underperforming or dysfunctioning and still test out within normal limits on pure tone audiometry. Okay? So that's really important that we all know that you can have, and hearing loss is a symptom, not a condition, just like tinnitus is a symptom, not a condition. The underlying condition is auditory neuropathy. All right, so the nerve that all that speech information travels along is underfunctioning, underperforming. And sometimes it's the hair cilia inside of the cochlea, right? And so those are the nerve endings that then communicate down into that braided nerve. Sometimes it's the nerve itself. There's a lot of evidence that suggests that tinnitus or ringing in the ears is that the myelin sheathing around some of that encases those nerves has started to erode. And so you're getting almost these electrical impulses that are arcing and sparking. And you can imagine a copper wire that starts to lose its insulation might get eroded or oxidized, or there might be water damage or something like that. So those things do happen with our neural connections. So it's really important to understand that by the time you have a socially impactful hearing loss, you probably have auditory vestibular nerve connections that look more similar to the top rope than the bottom rope. And what happens is, imagine if you were hanging a cinder block from a rope like this. All of the strands that are no longer attached, they're not doing anything. What's happening to the ones that are still attached? They are overloaded. They're doing all that work. And that's one of the things that can be really, really challenging when people even have a mild hearing loss, is they go, I don't think I'm quite ready for hearing aids yet. It's not that bad. And when we try to explain to that individual that what's actually happening inside of your body is that everything that is still working okay is working harder to make up for the parts of those neural connections that are no longer functioning well. So eventually that overload is going to lead to a cascading or progression of dysfunction, let alone what your brain actually uses to recruit along with your auditory vestibular and your midbrain auditory vestibular processing centers to help understand what's being communicated to you. And then you get cognitive overload along with the neural overload, and then you're a mess at that point, right? And that's usually when people come into our office and they say, help me, help me. And I say, man, I wish I would have gotten my hands on you 10 years earlier, 15 years earlier. Because some of this stuff can be, we can reduce symptoms. Some of these things we can help to bring back some degree of functionality. But some of these things, once it's done, it's done. There's no neurogenesis in the auditory vestibular nerve or the hair cilia inside of the ears. And neurogenesis is the regrowth of neural matter issues there. So think about that. To me, I found that to be the best representation for what hearing loss looks like. It has nothing to do with your ears or your brain. It's what's in between the ears and the brain. And it's usually more of a transit problem than it is a capture problem, if that makes sense. Okay, so the providers in hearing care, they kind of fall into these main categories, ENTs and MDs. And I think a lot of times we weight the otolaryngologists, the head and neck surgeons. We weight their opinions really heavily here. And I mean, with probably due reason. They've gone through med school. They've focused their academic careers in understanding what's happening in and around the ears. And then, of course, some of them go into cosmetic surgery and some other things, too. And they've never touched a hearing aid since they got out of med school. But the ENTs are probably creme de la creme when it comes to providers in our field. Audiologists are a clinical doctorate. Up until about 20 years ago, this was a master's level degree. It was then evolved into a doctoral program to help advance the science. Audiology itself, by the way, is only about 75, 80 years old. Prior to that, we really didn't have a big understanding about these things. Although we've been dealing with things like tinnitus and hearing loss ever since there's been recorded history, you can actually find comments by Hippocrates. So you've heard of the Hippocratic Oath, right? So Hippocrates, one of the fathers of modern medicine, discussed tinnitus and how to treat it. There are doctors from the medieval ages talking about, laying warm, freshly baked bread on your ear and praying your tinnitus away, right? And that was kind of like what we knew back then, and now we know that those things don't really get the job done. There's a hearing instrument specialist, and hearing instrument specialists are credentialed through the Department of Education in each individual state. There's no intrastate reciprocity, which means if you've been credentialed as a hearing instrument specialist in one state, you cannot practice in another state until you've been credentialed there. Many states, including New York, do have accelerated credentialing programs, but for the most part, someone has to go through an apprenticeship. In our practice, it's about a 3-year program to become a licensed hearing instrument specialist, and these are the hearing aid experts. So in New York State, audiologists with audiology degrees still have to become credentialed hearing instrument specialists in order to fit and dispense hearing aids. Oh, and by the way, so do ENTs. So if ENTs want to fit, and by the way, my 20-year history in the industry, I've still yet to meet an ENT that dispenses hearing aids. They don't do it. And if you don't do something every day, all day, how can you possibly profess to be an expert in it? Even ENTs whose, in fact, we just, this is timely, within the last month, we were contacted by an ENT from Boston, said, my mother lives in the area, I need to send them to a reputable clinic, can we send her to you? And of course, I might think to myself, why isn't she seeing you for, for her needs? And it's because ENTs do not fit and dispense hearing aids. They have opinions on hearing aids, without a doubt, but they don't work with hearing aids every day. And they're not up to date on the technological advances, the latest white papers that are out there, the research that are being done with hearing aids either, by the way. Doctors are amazing in our society, but they're just people. And it's something where often they need some additional supportive specialists in order to get the job done. To meet the advancing needs of a neurological, chronic, degenerative, neurological disorder like hearing loss. And then nurse practitioners, registered nurses, medical assistants. You may see in some practices where these folks are actually performing pure tone audiometry. Usually it is to rule out specific pre-surgical tests, but you will see that in some practices. By the way, they cannot fit hearing aids without being credentialed as a licensed hearing instrument specialist. And then, of course, if you go the OTC route, the Verizon Help Desk or the Best Buy Geek Squad may be who you need to entrust your care to, and I would say good luck with that. And then for many people, you are the provider if you are buying directly from a manufacturer, an over-the-counter hearing aid. And what I can tell you is that you are most likely not an expert to be able to self-diagnose, self-test, self-treat, self-service. That doesn't mean it's impossible, and it doesn't mean that there are not candidates that are appropriate for an OTC hearing aid, but it is very few of the hearing impaired population of the US. And by the way, it's the people who are the least motivated to address their hearing loss because it's not that socially impactful at that point. So these are the providers in the field. Are there any questions based on that list? Does anyone want to poke any holes in any of my reasoning so far? Oh, we've got a hand. Do we have a microphone? Oh, right over here in the blue shirt.
I just want to clarify then. I just want to clarify, you really should start with the audiologist to make sure you have a correct diagnosis and not go directly to the hearing specialist because you're old and you presume it's the same thing?
I think that you should just go somewhere. You could go to a hearing instrument specialist to begin with, and if the pathology of your hearing loss is complex, then they would refer you out, possibly to an audiologist, possibly to an ENT, possibly to an MD. So, for example, someone may say, I don't have hearing loss, I just produce earwax. And so, they may go into an office that is just a hearing instrument specialist, and that hearing instrument specialist may say, okay, let's clean out what earwax you have, and they may look into your ear and say, it doesn't look like there's enough to really impede your ability to perceive sound, but let me clean first, and now let's produce a test, pure tone audiometry, bone conduction, speech audiometry, and then they identify that there is, once I've removed the earwax, that there is hearing loss. But maybe it looks a little bit strange. Maybe it's more significant in one ear than the other, which we need to refer out. Any hearing instrument specialist needs to refer out. Any audiologist needs to refer out for that, by the way. Also, it's called asymmetric hearing loss. And that usually is an indication of one, maybe someone has a lifestyle or hobby where they get more noise exposure in one ear than the other. Think about people who shoot firearms and maybe they don't wear the appropriate amount of protection. A lot of people work in call centers end up with asymmetric hearing loss because they've got their headset on one ear rather than the other. Dental technicians and dentists get asymmetric hearing loss because of the constant drills. So you get sent out for an MRI. Because what we're looking for is there something in the internal development or anatomy of the ear that we can't see with a video otoscope or with an otoscope, right? Something behind the tympanic membrane. And it could be that you have a massive ear infection. You know, we usually would see signs of an ear infection. There would be some irritation, some red nature to the base of the ear canal, might even be oozing, you know, pus or something like that. If you need antibiotics, well, you need to go to a doctor that can prescribe you some type of antibiotic, and they can pharmacologically intervene and hopefully restore your ability to hear once they've gotten rid of the infection. So if there's no infection, asymmetric hearing loss, you don't have any remarkable hobbies or occupation that would cause an asymmetry in your hearing loss, then you go get the MRI, and what we're looking for at that point are things like an acoustic neuroma, which is actually a tumor growing on your auditory vestibular nerve. And because it's growing there, it's impacting those fibers that I talked about earlier, and it's impeding the messaging from your peripheral auditory system into your central auditory system. And at that point, we've got to go in and offer a surgical intervention. So you will be going to an ENT or a neurologist or a neurosurgeon who could then go in and remove that. And we have found in a very small amount of cases that you remove the tumor, you restore hearing to that ear, but usually you have to cut out a good part of the audiovestibular nerve, and you've got irreversible damage at that point. However, that is a much better outcome than not addressing that at all and having that tumor grow into your brainstem and killing you, right? So you could go to a hearing instrument specialist, and if they're worth their salt, if they're living up to the credentials and the license that New York State has bestowed upon them, they would refer you out. So would an audiologist. So I don't think that the credential itself is going to lend itself to whether or not someone can triage your needs well enough. Now, if you have no confounding concerns and you can be, your hearing challenges can be addressed with hearing aids, just stick with the hearing instrument specialist. I mean, New York State does a great job. I mean, it is the most rigorous state in order to earn a license. I mean, there's some states like Mississippi, you send them $75 and that's it. You don't even take a test, right? You know, New York State, you have to have, I think, 60 college credits, equivalent associate's degree, but many people have 4-year degrees or even master's level, or if you're an audiologist, you have a clinical doctorate, right? And they go through an apprenticeship where they have to work with a New York State licensed hearing aid instructor who has at least 3 years success fitting hearing aids, and then they become licensed. So the main difference between an audiologist and a hearing instrument specialist, I get this question all the time. Audiologists are credentialed by insurance companies, where hearing instrument specialists are not. And that's not all of the difference, but it creates a dynamic insofar as an audiologist will perform more verification and validation tests because they can get reimbursed for those, where a hearing instrument specialist can perform all of those same exact tests, but very few of them do, because they're either going to charge you for it, which you don't want to pay. I mean, many of us don't, if it seems frivolous or extraneous, or they're going to just do it on their own time. And a lot of the equipment is very expensive too. So the main differences between the two are just going to be the rigor that they might attack your conditions and your pathology with, and the amount of tests they're going to do. It's a little bit of an oversimplification, but you know, I've met healers, you know, with both of those types of credentials in our field. And I've met very lazy, underprepared people in our field with both an audiology and a hearing instrument specialist credential. So it really comes down to the individual that you're lucky enough to have in your town or that you're willing to drive to. That makes sense? Any follow-ups at all? Okay. So again, hearing instrument specialist, this is bolded because in order to fit and dispense hearing aids, you have to be one of these. It doesn't matter what your graduate level degree is. These two on the bottom would be if you were pursuing an over-the-counter hearing method So let's talk about an OTC update. This was a fascinating article that came out in the Wall Street Journal just a few months ago. And the reason I like to put these two things side by side, the one on the left is a screenshot of all of the articles the Wall Street Journal did on OTC hearing aids since the category was first described and then supported and policy was created by the FDA. And so they came out pretty strong. Hearing aids are going to change, the world. They're going to change and transform our medical industry when it comes to hearing care. And then you see over time, the headlines kind of get a little softer. Why aren't people buying them, right? And then suddenly, the hearing aid revolution that wasn't. And what we're trying to uncover, and at least what the author of this was trying to uncover, and what I've got a pretty good sense of what the answer is why don't more people buy over-the-counter hearing aids? Do any of you have a guess? They don't work nearly as well as a medical device supported by a professional with an expertise in making that device work specifically for you. There's this, so you're absolutely right, Len. There is this misnomer that hearing aids just amplify everything, and they should be as cheap as buying cheaters off of the rack at CVS. Now, with corrective lenses for vision, we give you one curvature that does magnify everything, or if you've got farsightedness, it does the inverse. But when it comes to hearing aids, we are manipulating the onboard processor at individual frequencies. Imagine if your glasses had to adjust for individual wavelengths of light. They would not be as cheap as they are, $6 or less, off the counter at CVS. So it's an apples to oranges comparison. That being said, there are some folks for whom their type of hearing loss is not complex, or they have affordability issues, and some solutions better than none. But I can tell you it's very difficult to make hearing aids, to optimize them. Does anyone know the name Les Paul? Any musicians in here? Okay. So Les Paul, famous guitarist and creator of a beautiful hollow body type guitar, which I think is the favorite of many, blues musicians throughout the years. Well, Les Paul was actually a hearing patient of an audiologist that I know, a man named Dave Fabry. And if you find Dave online, he's all over the place. He works for a company, an organization called Starkey, which is really the only major hearing aid manufacturer that's US-based. And when Dave was still in practice, Les was one of his patients. And Les would just beg him every appointment. You know that I've been working as a sound engineer and with other sound engineers my entire career. I make electronics sing in ways that people, laud me for. Give me that software. Let me tune in my own hearing aids, because I've got to be able to do a good job at it. And so the way Dave tells it is after months and months of kind of being like, Les, I can't do it, he finally says, you know what, take the software home, tell me how you do. And don't you know, 2 weeks later, Les comes back in, brings the software in, he says, I can't make these sound any better than you did. And so it's important to understand that just because something is web-based or software-based, it doesn't mean that we can all become experts in it, right? There's that idea of 10,000 hours. If you do anything for 10,000 hours, you become an expert in it. Well, don't expect to spend 10 hours on something or 10 minutes on something and be an expert. You have to spend the time at it. And OTC is just one of those manifestations. So what we see is that there's a lot of interest in an over-the-counter hearing delivery model, but there's very little stickiness. The other thing is most over-the-counter models, you're working in a mail-order relationship with the manufacturer, which means if you have a repair needed on your product, you're dropping that product into the mail, and you're sending it out to them. Now, has anyone shipped anything recently? What are the timelines like these days? It takes a little bit longer than it used to, maybe a lot longer than it used to if your stuff even gets there on time, right? And you're without your hearing aids that whole time. And then they make whatever repair they need to. They put it back in a box, they ship it back to you, you wait another 5 to 7 business days, so maybe you're 2-3 weeks without your hearing aids. And what happens if they show up and they're still not right? You send them back out. How many times do you think you need to do that before you go, I think I need a local professional to help me with this? It doesn't take much. So what we have found is that OTC solves for the affordability question, but it does not solve for the expert delivery of hearing care or the professional help. Does anyone know the name Dr. Cliff? Have you been out on, he's one of the more recognizable audiologists in the world at this point. I think he's got a YouTube channel with close to 67 million views on it, and he's an audiologist. And he's someone that I spoke with recently, and I asked him, because I've got my own thoughts on this, but I asked him, how many patients are out there that are in the wrong hearing aids, or even if they're in the right hearing aids, they're not programmed adequately for their needs? And he told me about 65-70%. I think it's closer to 80%. And it has to do with, one, people will select a hearing aid based on cost, not based on what their actual healthcare needs are. So they are underfit. They've got too little technology on their ears. They will buy from the wrong type of professional who doesn't want to see them for many follow-up visits. And I can tell you that the more data that we have, the longer relationship that you and I have, Len, if you keep coming back and we have 5 or 6 conversations about you only make it to that restaurant once a year, but you want to perform well listening in that restaurant. You know, it might be others, you know, you make it to church only on Christmas and Easter or you know, wherever it is that you might go, you still want to perform well in those environments. And we need to understand that. And that might not be something you remember on your first visit or your second visit or even your third visit. We have to know each other over time to really pull out from you enough information to expertly fit and maintain your hearing care. Oh, and by the way, your hearing loss is progressive, which means whatever it was on day 1, it's slightly different on day 366. And then what about a year after that? Right? And for some people, their hearing loss may stabilize for a little while, but for the majority of us, we have a standard rate at which the hearing degrades over time. And so you need constant reworking and re-articulating of the onboard software to get optimal performance out of your hearing aids. And you just don't get that at Costco. They don't want to see you back in there. They really don't. They make it very difficult to perform follow-up care. Has anyone had a great experience with follow-up care at Costco? Okay. Have a great experience with follow-up care, service appointments at Costco. Yeah. I always want to make sure that I'm not saying things with such authoritative nature and have someone in the crowd who's like, that wasn't my experience, right? I want to hear from you. You would be in the minority from what I've heard, and I've talked to a lot of people. But for people with very little needs for follow-up care, it is a decent solution for hearing care. So let's just talk about the professional delivery model. So this first piece, and this is a busy slide, and I apologize for that, but this first piece up here is a study that was done in 2017 with U.S. VA vets. So only 16% of vets who get free hearing care, free hearing aid, 16% of the vets adopted hearing aids despite no out-of-pocket cost. Right, so these are vets that had a treatable hearing loss. They understood that they had a treatable hearing loss, and they understood that the VA was going to give them to them for free, and 84% of them said, nah. Right, so affordability seems to not be a real driving factor here. The second piece is about taking a look at nations that have socialized healthcare, so European nations, Canada, where if you are a citizen, and you pay taxes, you get free health care. Well, in those countries, you're looking at, so Denmark had the highest rate of adoption at 42.5%. Right? So that means 57.5, right? %. The majority of people in Denmark with hearing loss who could get free hearing aids don't want them. Fascinating, right? In the U.S., this particular study said 33%. That's really high. I actually heard a study that from last March, so almost a year old now. It says we're closer to 12%. We were at 20% about 10 years ago, and we actually have less people adopting hearing care because there's so much confusion out there that they just don't know what to do, so they're not doing anything. It's really, really interesting. But again, if we're at 33%, as this study says, and there's only a 10%, just under 10% increase in adoption in the highest rate of adoption. The other piece here is that Japan, they do not have hearing care professionals. They treat hearing aids as a commodity, so everything is off of the shelf in Japan. They have a 10% adoption rate. 90% of people go untreated. And of the people who are wearing them, they have a 39% satisfaction rate. Speaks to what you had mentioned, Len. It just doesn't work, right? For many people is what I'm saying. Not for everybody. There are exceptions. This piece down here, this is a 2017 survey from healthyhearing.com. While 82% of the patients who were surveyed said, yeah, I'd pay for an OTC device that was $100 or less, which is not feasible to get a medical device that is worth anything for $100 or less. 94% said it was either very important or absolutely important to have a professional in their hearing health care circle, which is fantastic. And then this last one, again from 2017, we saw increased adoption rates for patients guided by a professional rather than those who had an OTC model, right? Which means of the entire category of people who could have gone forward with a hearing aid either off the counter, off the shelf, or with a professional, that we actually saw a 20% increase of people saying, I'm going to do this, whether it was the confidence of having someone that could help them, maybe they had someone they could even just ask questions of. I mean, go try to ask, the Best Buy person, what about these hearing aids do you really like? Do you think this is right for me? You know what they're going to do? They may say yes, but they're probably going to take the box out of your hand, turn it around, and read the back of the box to you. Like you didn't already read the box before you called them over, right? So it's just, you get what you pay for in a lot of ways in life, but it is also in healthcare that you've got to be very clear and conscious of these things. So let's talk about cost anyway. So the very first hearing aid in 1920, the Williams Articulator Carbon hearing aid sold for $120. If you plug $120 into an inflation calculator for 2020 into 2024, because I did this before the end of the year, $1,882 for a hearing aid back then. And if you kind of scroll down through here, you can see by 2000, the average cost was $1,100. So hearing technology had actually gotten less expensive for the value of the dollar, in that time period, in those 80 years. By 2016, we were up to $2,400. This was kind of the advent of the digital hearing aid, where we went from just pure analog amplification, which didn't work for anybody. If analog hearing aids that just amplify everything worked, we'd still have analog hearing aids. But we don't. We have these digitally programmable hearing aids that are hugely more effective. And then in 2024, last year, the average price for a hearing aid was $2,500 nationwide. One. Yep. So you'll have some people that may buy a pair for $3,000, and other people will buy a pair for $6,000, and then some will buy a pair for $4,000, some for $5,000. I've seen hearing aids today, premium level, go for as much as $9,500 for a pair, and as little as $4,200 for the best hearing aids you can buy. It's really interesting the way that things are marked. And what I would tell you is, so at Costco, where you can get premium level hearing aids for $4,200, $4,400, $4,600, whatever the number is today, you're not getting the follow-up care. And of course, that's their entire business model, is sell at high volume with a low margin and provide very little care after the fact. That's why they do real ear measurement, and we'll talk about real ear measurement in a minute here. But real ear measurement is a way to verify that the output of the hearing aid is meeting what the prescriptive needs of that patient are. So they try to get as close to prescription on day one as they possibly can so they don't have to see you back ever again. And as I described, this is a rehabilitative process. I I mean, can you imagine if you were rehabbing post-surgery or if you torn a hamstring or something and you went to a physical therapist and they said, I want to see you do a couple exercises for me. Okay, great. Here's your sheet. Go home and fix yourself. It's a rehabilitative process here. It takes time. Oh, and by the way, your brain is acclimating to the stimulation that it wasn't getting before. And suddenly we're just going to give it all to you and tell you just to white knuckle your way through it. I mean, it's one thing when you get a new prescription with glasses. And I know I wear contact lenses, but when I get my prescription updated, I may have an afternoon with a headache. I can feel the strain in my eyes a little bit, but, I eventually, can regulate to it. It's much different than what happens with hearing aids. It can be way too much. In fact, when we fit a new hearing aid wearer to prescriptive levels, a lot of times they go, whoa, that's too much. And so we titrate it back, and then we step them back up over time. But what happens if they never come back in? They're set at that weaker level below prescriptive level from there on out. So we got to get you to come back in so that we can get you back up to where you need to be. Is this interesting? I found this to be so interesting about the cost of hearing aids. And the funny thing is, I don't know if it's funny or not, 2016 doesn't seem like that long ago, does it? Almost 10 years ago now, right? Yeah, has anyone seen what the real estate market has gone since 2016? What about a new car? Do you know how much a new car costs now? $45,000, average cost of a new car. In the mid-90s, it was like $8,000 was the average cost of a new car. Everything has gotten more expensive, but hearing aids have only gotten a little bit more expensive. So when you actually take a look at the relative cost, hearing care is cheaper than it's ever been before. It's really, really interesting. Now, that's cold comfort, when you're being asked to lay out a couple $1,000s or several $1,000s, but it is the truth. Okay, so what tests are important? Pure tone audiometry, we talked about this. This is the audiogram. This is where you see the standard plot graph of your frequencies, right, delivered in hertz, and then the volume associated with how loud was that beep, and you plot out there. So pure tone audiometry is very important. Bone conduction, this is how we see how well you hear by sending vibrations through your skull, because we actually hear with our bodies. We've got these 3 tiny, tiny little bones in the inner ear that vibrate, and we can pick up information, sound information. That's why people who are considered deaf, they can stand in front of large speakers, and they can dance to the vibrations, right? Because they can feel it in their bones. It's really fascinating. So bone conduction, and then speech audiometry, which is a collection of both speech recognition thresholds and word recognition scores, and that gives us speech discrimination. And that's really important. This is where, the magic happens, to tell you the truth. How many of you communicate with your friends in a series of beeps and tones? Not R2-D2, right? But the first test that your hearing professional does for you is how well can you hear these beeps? The number one complaint of people with untreated hearing loss is what? I can't hear what? I can't hear what people say. So you walk in and you say, I can't hear what my friends are telling me. And they go, great, I'm going to see how well you can hear these beeps in a quiet room. It's like, wait a second. That seems to be unrelated. Of course, I'm being glib here. Pure tone audiometry is very necessary for the medical and rehabilitative nature of effectively identifying what you can perceive. But it is invalid when it comes to your ability to recognize speech in competing background noise, which is the number one complaint. Oh, by the way, do you know what the number one complaint of people who wear hearing aids is? Can't hear noise. I still can't hear the speech that I want to hear. So there's another, I think, piece that helps us understand that many people who wear hearing aids are not dialed in as well as they ought to be. Tympanometry, this helps us diagnose middle ear function, which is really important, also called an impedance test. Otoacoustic emissions, this helps us to understand cochlear function. This will be done sometimes with very young children because we don't need them to respond back to us to give us data if they heard something or not. We basically can understand through echo. It's really cool the way it works. but the the hair cell activity inside of the cochlea. So there are actually some audiology practices that will start you with OAE and say, yes, you have cochlear dysfunction. You do have hearing loss. Let's go into the booth now and find out exactly how bad it is. And that's fascinating to me. And by the way, all of these tests that I'm mentioning can be done by both an audiologist or a hearing instrument specialist. Only the audiologist can be reimbursed by insurance for it, so most of the hearing instrument specialists don't do it. Speech and noise test. This is perhaps the most important test to be done to understand your functional communication challenges. Right? So again, if your number one complaint is to understand speech and competing background noise, I want to, as a hearing professional, I want to introduce background noise to create as lifelike a real-world scenario as I possibly can and see how you perform in it. And then when you can't hear or distinguish the voice in the noise, I go, there it is. There's your hearing loss. Oh, and by the way, you can fail a speech and noise test, walk into the booth, and test out within normal limits on pure tone audiometry. And there's some patients that go, thanks, I don't have hearing loss. Well, yes, you do. I just needed to use a secondary test in order to verify it. And that's the piece that a lot of people don't get. OTC, by the way, you're only going to get pure tone audiometry. No bone conduction, no tympanometry, no OAE, no speech and noise testing. Just pure tones. Auditory brainstem response, ABRs. This is part of a category of testing called electrophysiology audiometry. This is done also, again, with newborns. So you wear a small cap or a little headband, and we introduce sound. And we know that based on the sound we're introducing, that the brain in the auditory cortex should light up in a certain fashion, and if it does, you hear well. And that's how we can tell if a newborn has good hearing or not. Oh, by the way, we can do the same thing with people in vegetative states, and their brains light up the right way. Do you think they're processing speech? Of course not. They're not communicating. So the human body is so fascinating. We can capture information, fine. But if somewhere along that auditory system, or once it gets into the central auditory cortex, if it's not being processed well enough, you're going to have hearing challenges and listening challenges and communicating challenges. Oh, and by the way, if you're anxious, if you're over-caffeinated, if you're distracted, if you haven't had enough sleep, your processing speed slows down. So you may have practical, functional communication issues, but you just got to clean up your lifestyle. You know? Easier said than done. I don't want to give up my coffee. You know? I've been binge watching Netflix all night, you know? So I'm a little bit slower this morning. Who cares, right? But yeah, it adds up. And that's why when you work with a provider, you should work with a provider that wants to know more about you. And they're going to ask you questions about your health care that are not, may seemingly be unrelated to your hearing health, but it's all connected. It's all connected. And by the way, caffeine, chocolate, lack of sleep, stress and anxiety, all of those things also flare tinnitus symptoms. So for anyone who's looking for a special tinnitus product that's going to make your tinnitus go away, but they want to keep drinking, you know, a pot of coffee every day, you know, or not getting enough sleep, or being really stressed out. I mean, sometimes I'll tell you that. So AAO is the American Otolaryngology Association. So this is the trade association that credentials and regulates ear, nose, and throat doctors. When they talk about treating tinnitus, they can only, with a high degree of confidence, support one treatment for tinnitus. Do you know what it is? Prescription hearing aids. Because the underlying condition, tinnitus is a symptom, the underlying condition is the auditory neuropathy. So if we can get enough signals, prescriptive signals, into that auditory vestibular nerve that is being overtaxed and overloaded, You actually see a reduction in tinnitus symptoms. They will say that for folks where that isn't enough, and by the way, it takes 12 to 18 months of wearing hearing aids to start to see some real beneficial decline in your tinnitus symptoms. I mean, some people see it right away, but to see it long-term reversal or dampening of your symptoms, you can never, there's no cure for tinnitus, but you can reduce your symptoms by, 90% of people can reduce their symptoms significantly. But you can reduce it, but it's really important to address the underlying auditory neuropathy. And then for folks where the hearing aids aren't enough, the next thing that they recommend, and these are the ENTs, is cognitive behavioral therapy. Because maybe you need mindfulness to deal with things like anxiety. Maybe you've got anger in your life. Maybe you've got relationships that are unfulfilling. Maybe you've got kids that just won't get their act together right. I don't know what it is, right? But it's something that's driving you crazy, and it's driving your tinnitus up. They have a position on acupuncture, by the way, that says that there is emerging evidence that is promising, but it's still way too few data points to be able to support any degree of confidence in a recommendation. But acupuncture is something that's at least interesting. They say, don't eat ginkgo biloba, don't eat certain supplements. Now, if you're not sleeping well and you want to take melatonin, if it's a sleep hygiene problem, eat the melatonin. But there isn't a special, tongue zapper or, the intracranial magnetic, therapy stuff. That stuff is just not surgery. None of that stuff is recommended by the ENTs. Okay, where was I? Here we are. Real ear measurement. I talked about this earlier. So this is where we put a little probe right in between the hearing aid and your eardrum. And what we're trying to recognize is if what the onboard software is producing is what's actually coming out by the ear. And sometimes it's not. And sometimes it's that the hearing aids weren't set up well. And sometimes it's that the hearing aids don't perform well. And so that's something that we need to go back and recalibrate. And then electroacoustic analysis, something Len and I were talking about that was fascinating. This is where we actually start to understand the onboard diagnostic performance of the hearing aids. Do any of you own laptops? How's your laptop running these days? Pretty good? Is it new? No? You must have good memory hygiene on your laptop. For most people, they know that they get the sense that their laptop works great on day one. But once I've had it for a while, it slows right down. And what it is that the heat that these things generate, they've got fans to try to cool them off. Well, of course, what the fan does is creates airflow, and that airflow sucks a bunch of dust and other things that can get in and gunk up the connections on the onboard processing circuitry. There might be ambient moisture, depending on where you live, if you're in Florida half the year, whatever it might be. So suddenly you've got all these things that impact diagnostic performance of your laptop. Well, I can promise you that the human body is an inhumane environment for a medical device with a processing chip to perform well all day, every day for years and years and years and years. There are ambient amounts of moisture around our body. I mean, we're kind of like a mist tent. Have you ever been in a misting tent, right? Or maybe at the grocery store where that's happening just off of your skin. And fluid is sublimating off of our skin at all times. It's really kind of crazy. We have these fluctuations in temperature on our bodies throughout the day, throughout the night. We secrete trace minerals, oil. Earwax is a big deal, guys. It really is. I work in hearing care. I'm telling you, earwax is no good for your hearing aids. We inadvertently spray our hearing aids with our hairspray. We jump in the shower with them, right? So the diagnostic performance decays over time due to those factors. But these circuits are also minute. These are micronized microchips, right? So we've been able to, through robotics, create these tiny, tiny, tiny microchips. And they just don't hold up well, especially when most people wear their hearing aids from the moment that they wake up to the moment they go to sleep. That could be 12 hours for some, 16 hours for others, day after day after day after day. Anyone with a cell phone in here? How's your cell phone battery work these days? You have all the good electronics. I got to figure out what you're doing right. I'm doing it all wrong because my batteries don't hold up after like 2 or 3 years with my cell phones. So it's the same thing. You know, the more use you put into these things, the less well they're going to hold up. So this diagnostic decay happens. So what we do is when we receive a hearing aid wholesale from a manufacturer, we run electroacoustic analysis to make sure that the output from that hearing device meets manufacturer specs. Right? It's like taking that Jaguar when it gets off of the truck at the Jaguar dealership and making sure that it revs certain RPMs, you know, when the gauge says is that, you know, 7,000 or whatever it might be, right? So we want to make sure these things are working well. So we do, and what we actually find is that close to 25% of hearing aids that we receive wholesale directly from the manufacturer are underperforming specs. So we send them back. And not every practice does that, guys. So you may have a lemon in your ears and not even know it. All right? And then over time, we continue to track and to optimize and to make whatever characteristic changes we need to within the onboard software to give more output to make sure that what's being driven out of the small speaker is what's supposed to be there. The other thing we also do is that we perform dehydration with hearing aids as they come in, and we pull microliters of water out of these tiny circuits. And I can promise you that patients hear an audible difference. They can hear the difference between before we put it through the dehydration unit and when it came out after. It's fascinating. So it's really important that you work with a practice that might do that for you. And again, real ear measurement and the electroacoustic analysis, this is device performance measures. Everything else is about your ability to hear. So these are verification and validation where we can triangulate. And again, gang, you may come in within normal limits on pure tone audiometry, but have functional hearing challenges, and then we can identify it some other way. And it's cold comfort. It really is not, you know, we have families that come in all the time, and maybe the target patient we're working with says, my wife won't give up. She says, I have a hearing problem. And the wife says, he does not hear like he used to. And then we put him in the booth. We do pure tone audiometry. Congratulations, you don't have hearing loss. He feels validated. She feels very much invalidated. You think we fixed anyone's problem? No. We certainly gave him a reason to be like, okay, I'm not listening to anything else you have to say either, right? But when we go and we do speech and noise testing, and he fails miserably, we say, okay, it's clinically proven you can have 80% degradation in that neural connections, right? And still test within normal limits, which is fair. You know what? It's actually something you should be very proud of. You've got great neural connections. The ones that are there are doing a decent job. It won't be like this forever. Eventually, it'll start showing up on the pure tone audiometry. It is showing up, however, on some of these other tests. And if you're willing to let us treat you and take them home and see if you don't do better in conversations, let's do it. And then usually what we get back, we report back, it's like, oh my gosh, I had no idea it was that bad. It's been night and day. And she says, oh my gosh, he's got pep in his step back and everything's great, and respect and trust is building between them again. So you got to be careful to rely too heavily on pure tone audiometry. It is a good test to do. It has a very important place in medical and rehabilitation of hearing loss. But it should not be the sole thing you rely on. It misses too much. By the way people read the results of an audiogram can vary as well. Some people might look at your audiogram and say, yep, you've got a treatable hearing loss. Where someone else with the same exact credentials might say, you know what, it's pretty early. I think you're probably good for another year. We'll see you next year. Trying to do you a favor by saving you money. I'm telling you guys, it is very, very interesting out there. You need to know for yourselves what you're up against. So pure tone audiometry is the only thing you get with an OTC model. If you want to learn more about speech and noise versus routine audiogram, Matt Fitzgerald, who's PhD It's Stanford Otolaryngology, Stanford Audiology. You can find this on YouTube, Speech and Noise versus the Routine Audiogram. Watch it. It is a 55-minute lecture. You want to hear someone who's passionate about hearing loss and speech and noise testing. He does a great job. I'm not going to play any of it for you here, but I just wanted, for those of you that want to do more homework, he does a great job at showing why speech and noise testing is much more of a practical, functional test. It's also been proven that speech and noise performance, the performance on speech and noise testing is a much higher indication of cognitive performance than pure tone audiometry is too. So if you've got any history of vascular dementia, Alzheimer's, if you are at a higher risk for dementia based on lifestyle choices or any other healthcare conditions, speech and noise testing is the way to go. It's going to give you a clearer idea of what you might be able to expect over the next few years. All right, so let's talk about the right device. And this was something that Len and I went deep on when we were here. We're going to go a little bit deeper. So here are the characteristics of diagnostic performance of hearing aids. First is frequency range. How much of the perceptible range of frequencies that humans can hear does your device actually process? And you can see that between 250 and 5,000 hertz is what most OTC hearing aids will process. They don't even go to 8K. Right? They don't even go to 6K. Most prescriptive hearing aids will go either to 10 or 12,000 hertz. So that you can get those extended high frequencies, the change jingling in your pocket, the birds singing in the tree, the wind moving the aspen leaves, the leaves crunching underneath your feet. These are extremely soft, extremely high frequency sounds. You won't get those with an OTC device, but you get those with a prescriptive hearing device. So what you should do is anytime you're looking at a hearing aid, so let's say you go to an audiologist and they say you should be in an Oticon Intent, or you should be in a Phonak Audeo Infinio Sphere. Go to that manufacturer website and find out what the frequency range is. Make sure it's giving you the full range of, it can process the full range of perceptible frequencies. Latency, this is another word for delay. So you can see that the new rule for OTC said that it cannot exceed 15 milliseconds. That sounds like a pretty short amount of time, right? Well, understand that prescriptive hearing aids are below 1 millisecond. So when the sound information hits the microphone on the back of the hearing aid, gets processed through the internal circuit, and gets pushed out through the speaker, 1 millisecond. Natural sound, as close to it as we could get. OTC hearing aids have to be within 15 milliseconds, again, day one. Well, what happens? You think OTC doesn't have the same type of diagnostic slippage as a regular hearing aid will? So you're going to start hearing things like an echo, a very faint echo. I can see Len's mouth moving, but I don't hear it until it's just a little bit behind, It's like bad dubbing on an old movie, You don't want that to happen because you're just going to be more confused. You actually have to incorporate things like memory when those sorts of things happen, and you're overloading prefrontal cortex instead of keeping all of your auditory processing in the midbrain. Circuit noise. Again, they put limits on how loud the circuit can actually process. 32 dB, that's louder than a whisper. So if it's processing and it's delivering noise to you that's louder than a whisper, you think it's going to be distracting? Possibly, right? So you can see that prescriptive hearing aids test somewhere between 16 and 20 dB. Distortion, so the signal gets distorted. So if you can't perceive 8,000 hertz, there's something called frequency compression, where you can compress those noises down into a frequency that you can perceive. And when you compress the sound, it changes a little bit, right? And anytime you process sound, it gets changed because it goes from a very natural, sound waves are these undulating or very staccato speech, but it's waves through the fluid nature of the gas in the air, right? That sounds weird. It's a gaseous nature of the gas in the air, but it exhibits something similar to fluid dynamics. When you process everything becomes digitized or electrical. So there's a change to it. So there's a certain amount of distortion that can take place. You have to be aware of how much distortion the manufacturer's specs are on the hearing aids that you're looking at versus prescriptive hearing aids. And then the materials, you want to make sure that they're not being made out of something that's either going to be uncomfortable or possibly not integrate or seat directly with your skin in a way that works. Silicone is now the industry standard for things like hearing aid domes because silicone tends not to irritate, tends not to inflame or cause infection. Silicone's pretty user-friendly. Silicone, by the way, is a petroleum byproduct. I'm sorry, it's a sand byproduct. But if you're going to be using something that's not silicone, be careful. Also be careful about insertion depth. You don't want to be shoving anything into your ear by yourself if it's going to go too deep, because you could risk scraping or damaging the very thin, paper-thin skin on the inside of your ear canal, or possibly even your tympanic membrane, your eardrum. You want to be careful there. Okay, all these performance specs degrade over time, even in prescription hearing aids, but you're starting at a much more precision level of diagnostic performance that you will decay from. That makes sense, right? You know, if you start at a lower level of performance and that decays, before you know it, you just get a bunch of garbled noise. So this is really cool for me, and I geek out about this. Some of you might be like, yeah, I don't know. But these are the things you need to think about when you're selecting a device. Any questions about that at all? Okay. Hearing Tracker, I think, is a really good website to go to if you really do want to do comparison for hearing aids. I've got my own favorites. Hearing Tracker will tell you what they think. One of the things that Hearing Tracker does really well is they partner with HearAdvisor, which is one of the largest and most skilled diagnostic testing facilities for hearing aids. And they have no bias whatsoever. They will tell you if a hearing aid's doing what it's supposed to do or if it's not. And they're very direct about it. So if you want to go on and read some reviews of, you know, OTC or PSAPs or even some prescriptive hearing aids who say that they're supposed to perform a certain way with characteristics of the sound that they're processing, HearAdvisor will tell you it's not coming close, or that it is. So I would say those are two websites that you can go on if you're really interested in. Busy slide, I'm not going to go through the whole thing. The number of quality of life improvements that come with treating your hearing loss, they're myriad. They are well researched, well evidenced. If you have hearing loss, you should be in treatment. Period. We don't live in a world anymore where it's okay to not treat your hearing loss. You know, there are many people who still smoke when there's plenty of evidence that says it's probably not good for you, right? And there are people who won't treat their hearing loss, but I'm telling you, it is not good for you to not treat your hearing loss. So get out there and do it. If it's a vanity concern, if it's a stigma concern, even if it's an affordability concern, there are resources out there that you can work through to get the help you need, but treat your hearing loss. And the good news is you see all sorts of things. I mean, cognitive performance improves, which is fantastic. You also reduce your risk of catastrophic falls, which, you know, definitely are something to be concerned about. You improve your earning potential. I know many of you are not working anymore, but for anyone who is in the workforce, for similarly skilled workers, people with untreated hearing loss make about 30% less, and if you treat your hearing loss, you can close that gap by about 95%, so you can almost gain it all back just by treating your hearing loss. Do you guys want to go through these case studies or no? You want to go right to questions? We don't have time. Okay, any time for questions? Are there any questions at all? All right, we've got one right here in the red.
I am wondering about this Audicon newest version where this got AI in it.
Yes.
Can you say something about that?
Yeah, so the Oticon Intent, and it's actually a year old now, and it's got a deep neural network, and they actually were using a deep neural network on the previous version of their hearing aid as well. Almost all the manufacturers are using some version of artificial intelligence from a very rudimentary sense of what artificial intelligence is. What they're using inside of the intent is to understand where speech is coming from and the speech that you want to hear, and to help distinguish that speech from competing background noise. Some people find it to be very, very effective. Phonak has a great product with artificial intelligence where their artificial intelligence actually uses their AI as a filter. So it's been trained, the large language model has been trained on speech information, so it can understand and recognize, identify speech very quickly, and it upregulates speech, so you hear it, and it downregulates everything that isn't speech. So it actually can give you a more enhanced listening experience. But none of these are learning in real time, right? Because you need a lot of computing power to have an AI that's learning right now. So what it is the AI was trained inside of a compute facility, and then once it learned what it needed to learn, and I think Oticon trains their AI on like 12 million different, audio files. I think the Phonak one is 24, something like that, 24 million. But once they train it, then they put it into the chip, and actually Phonak has a secondary chip, so it's a little bit more power hungry. Actually, so does the intent from Oticon. But it's not the type of AI that you think of, that it's going to think for itself and do what it wants. The AI has trained the chip to do what it needs to do, and then the chip filters speech information better. It won't. Well, so here's another thing, too. Hearing aids today speak to one another, and that's only been about 10 years the FDA has allowed us to do that. Before that, they would not let us create hearing aids, the industry, create hearing aids that had bilateral communication. For anyone who's been wearing hearing aids more than 10 years, you might remember you used to have to wear a pendant around your neck, and the hearing aid would speak to the other hearing aid through the pendant. Now they go right through the skull. So it's not so much the AI that I'd be worried about infecting your brain as it is the wave signals. It's like, it'd be like taking your phone and just, you're not supposed to sleep with your phone next to your head when you sleep. Well, you wear hearing aids all day and they communicate. So I don't mean to scare you at all. AI and hearing aids is not going to do anything to your brain. It's going to help you hear better. Go ahead.
You mentioned earwax as a problem. How often should we tend to get it cleaned out?
Yeah, it really depends. Some people produce more earwax than others. And earwax production is extremely natural. It's meant to fend off infection, help your body naturally remove things like dust and dirt, airborne dirt and things that can get into your ears. I mean, even microbes and that's why it's so sticky. It wants to, stick and infuse itself with any of these foreign bodies and then naturally fall out. But for some people, it doesn't naturally fall out. And so it should be cleaned, really depending on the nature of your own production of earwax. We have patients who come in weekly because they produce that much wax. We have other folks where it's about every 4 months. Many of our patients are as needed. So you'd know if you're a producer or not because it'd be something you would have been dealing with most of your life. And then, of course, if you're sick or if it's, if it's springtime, people produce more earwax. Summertime, people produce more earwax. Winter, it's a lot less. Yeah.
I think we should probably finish up.
All right.
Thank you so much.
Thank you all very much. I hope that
Great
wasn't too
information.
much.